A versus T1B. Upstaged PT3A patients tend to do equally well as T1A patients. So these are a couple of studies. I'll go through the EORTC data, which he'll quote. The only randomized trial comparing radical and partial, which showed radical to be of some benefit, but it had low accrual and premature closure. The number of patients were almost half. The size of tumor was less than 5 centimeters. So this is an older trial, 10 years before. Technological advances have pushed the boundaries of feasibility, and 3D recon has really helped in achieving better outcomes with robotics, improved surgical planning, patient counseling, resistance strategy, clamping strategy, reduction of complications. And this has been borne out by a recent study, meta-analysis, 13 studies including 2 RCTs, that the ischemia rate is less and the post-op complications are also less if you have 3D planning, and the trifecta achievement is better, 55 versus 45. I will skip through this video, but this is a case which I did for partial. Okay, I'll just skip through. Yeah.
So come to the conclusion.
Yeah, I'll just come to the conclusion.
The
guidelines,
you should stop now.
Say the same things. Partial whenever possible. So the focus is on the longer game. We should be focusing on long-term surgical outcomes of improved renal function, and we should do it. This is the concluding slide. Partial nephrectomy should be done whenever it is feasible, and provided, of course, if it is safe. I rest my case. Thank you. Sorry.
Thank you, Dr. Bakshi. May I invite Dr. Vrusabhanu Nayak, who is an additional professor in uro-oncology from AIIMS, New Delhi. So you have 7 minutes.
Thank you, Sogo, for the opportunity. So I'll be speaking against partial nephrectomy should be offered whenever feasible, no disclosure. I do understand most surgeons, they like challenges, they like enjoy the thrill, and many surgeons may actually do have an orgasm while doing some exciting and challenging surgery, but then you should understand at what cost you would like to get that orgasm. So this debate of whether partial nephrectomy should be offered to all patients whenever technically feasible, this is nothing new. This is an ongoing debate over the last decade. So this is an editorial published in 2012. This editorial actually does speak about that only randomized control trial that is available, URTC trial on kidney tumors less than 5 centimeters with normal contralateral kidney. And that trial does show the overall survival at 10 years favors radical nephrectomy than partial nephrectomy. And this editorial also mentions regarding no higher morbidity and mortality and end-stage renal disease in donor nephrectomy over the long run. In that URTC trial, the reoperation rate following partial nephrectomy was twice as high than that of a radical nephrectomy, and for the complex kidney tumors, the nephron-sparing surgery actually comes with a risk of more than 20% major post-operative complications. It's not only 100 ml extra blood loss. So whether the technical feasibility should be the main guiding factor to decide the treatment option, that answer should be emphatically no. You should consider the oncological outcomes, development of the CKD that is being mostly talked about by my previous speaker, and the complications. So when you talk about the comparing the oncological outcomes, this is a paper, the long-term follow-up and the perioperative outcomes for partial versus radical between 4 to 7 centimeter size, systematic review and meta-analysis that shows the 5-year cancer-specific survival and 10-year cancer-specific survival better in radical nephrectomy than partial nephrectomy. Again, this is another paper comparing the survival outcome in T2 tumors between radical and partial. This paper says partial nephrectomy may be oncologically effective in T2 tumors, but for a renal nephrometry score of more than or equal to 10, it is negatively associated with overall survival. So for higher complex score, partial nephrectomy actually poor overall survival in the long run. This is again another systematic review and meta-analysis for T1 and T2 tumors. This review has actually shown there is not major data comparing T2 tumors between partial and radical. Some studies have shown oncological outcomes are equivalent. However, there are studies which have shown for tumor more than or equal to 7, the oncological outcome with partial nephrectomy is poor. So this systematic review has actually concluded for T2 tumors, partial nephrectomy should be more selective and specific patient and tumor factors should be considered rather than just a technical feasibility. Again, this is a Cochrane review that has actually come up with T1 and T2 tumors, and this Cochrane review has also shown for time to death from any cause is poorer with partial, serious adverse events are poorer with partial, but for secondary outcome like cancer specific survival and time to recurrence, there was no difference between partial and radical. The perioperative bleeding was significant with partial, the urinary fistula are significant with partial than radical, though the reoperation rate was no different between the two groups. But the long-term adverse event that was being talked about, like CKD and liver-related and CVS-related mortality, this Cochrane review has shown there is no difference in the CVS-related mortality and the liver-related mortality and the kidney-related mortality in the long run. So the oncological outcome, there was no difference between partial and radical as per this review. The perioperative complication was significant with partial, but the long-term adverse event like cardiovascular-related mortality and kidney-related mortality was similar between the two. So this is again another paper, partial nephrectomy, like if you offer partial nephrectomy for a clinical T1 disease which upstage to T3, this is a paper from Journal of Urology which has shown if you offer partial nephrectomy for a clinical T1 which is pathological upstage to T3, the recurrence-free survival is inferior in partial nephrectomy. So as for the oncological outcome is concerned, it is still, the jury is still out on the topic. For the complex tumors and T2 and higher tumors, the oncological outcome is not very good with partial nephrectomy, though there are certain studies which have shown equivalent oncological outcome. Then the next thing that needs to be considered regarding which has been actually spoken about, like the development of the CKD. This is a paper on survival and functional stability in chronic kidney disease due to surgical removal of the nephrons. They have, over a period of like 30 years, around 4,000 patients, those who underwent surgery for kidney cancer. Those patients were divided into three groups. One group, those who did not have CKD before surgery, and also after surgery there was no CKD. That was one group. The second group was no CKD before surgery. They developed CKD like GFR less than 60 after surgery. That was the second group called surgical CKD. The third group was to start with they had a pre-existing CKD and then they end up with GFR of less than 45. That was surgical plus medical CKD. When in long run, the renal stability and non-renal cancer mortality were compared between the three groups, there was no difference between no CKD and surgical CKD. Hence, surgical CKD was associated with more stable renal function and better overall survival than medical CKD. Again, this is another review, is all chronic kidney disease created that are equal? If you look at this Kaplan-Meier curve, the upper part is the patients with no CKD, the green line patients with a surgical CKD, and the red line is patients with medical CKD. The overall survival is no difference between patients with no CKD or patients with surgical CKD.
1 minute left.
So again, the guideline, European guideline panel recommendations, these guideline panel recommendation actually has shown there is very limited evidence on the literature for the optimal surgical treatment of patients with larger renal masses. Retrospective comparative studies on clinical T1 and clinical T2 patients who are upstage to pathological T3 shown contradictory results, though some studies have shown equivalent oncological outcomes. But the recent report have shown partial nephrectomy actually has a significant shorter recurrence-free survival, and the overall evidence, level of evidence is low, and these studies which included T2 masses have a very high risk of selection bias, particularly on balancing the patient's age, comorbidities, tumor size, stage, and the tumor location. And the panel's confidence on these results is limited, and the true benefits of effects may be substantially different. Hence, the guidelines panel recommend the risk and benefit of partial nephrectomy should be discussed with patients with T2 tumors. In this setting, partial nephrectomy should be considered if technically feasible only in patients with solitary kidney, bilateral tumors, and those with existing CKD. So the guideline recommends partial nephrectomy T2 patients only in a solitary kidney, chronic kidney disease, if it is technically feasible. Finally, I'll end again with another review. This is a review published in European Urology in 2017. The review was shown for the larger and more complex renal cancer. nephron sparing surgery can be performed if it is oncologically and technically safe. Oncologically safety still it is not very clear. And in the presence of a normal contralateral kidney, radical nephrectomy will only induce CKD and impact on overall survival in exceptional cases and is not inferior to partial nephrectomy in the long run. So when the take home is the result of oncological efficacy, it is still controversial, the jury is still out. On the development of CKD, there is no practical benefit of partial over radical on the long run. Surgical CKD is as good as no CKD. Perioperative complications is more with partial than radical for larger tumors. Surgical oncological controls remains the number one priority. There is no curative systemic therapy available to salvage the unresectable local recurrences. Recurrent disease is always potentially lethal. The only RCT that is available doesn't show any benefits of partial nephrectomy. So in the end, you need to decide whether you want to jump from a 30 feet height on a concrete floor and die, or you want to jump from a 10 feet height on a sand beach and go home little injured. So one can do it, doesn't necessarily mean one should always do it. It's better to be safe than sorry. Thank you.
We like to thank
So
We like to thank both the speakers. They have put their points. Only one thing I want to add is if we should always check the function of the contralateral kidney by doing a dynamic renal scan. And if GFR is more than 45, then you are safe in this particular group of the patient T2, that what we are talking. And so the renal function will not be affected if other kidney is normal. The second thing is technical feasibility, and the experience of the surgeon is very important. Whether if he is experienced, he should think over it, then only he should embark on partial, otherwise radical is better. And third thing is the approach. Again, robotic is there, no doubt, but if you think that it is not feasible with robot, one should not shy by doing a open partial nephrectomy. This has been my experience of last 30, 40 years, what I have seen the changes in this kind of surgery. Anyone else like to make any quick comment? Otherwise, we close this session. Yes, Abhishek.
Sir, apart from the formula that you were alluding to, which Dr. Campbell always talks about, that the new GFR will be multiplication of the global GFR into contralateral GFR into 1.25. So adding to this factor, we are now going to get a histological estimate by newer modalities. So something which is more like a clear cell is more likely to be capsulated. So the chance of it being T3 is slightly lesser than papillary or even for that matter chromophobe. So what is concerning is that the tumors like oncocytoma, they are not perfectly capsulated. So when they are present in the center of the kidney, they also turn out to be something like T3A. And the pathologist reported it as oncocytic neoplasm of undetermined malignant potential. So sir, these will also contribute to a pool of T3A, and the statistics that we have will get skewed in a time to come.
Okay, thank you for your comments.
thank you, sir. We now have a panel discussion. May I request the chairpersons to please come down and be seated in the audience while we have the panelists on the stage. To moderate this session, I would like to call upon Dr. Gagan Gautam, who is Vice Chairman, Uro-Oncology and Robotic Surgery at Medanta Kidney and Urology Institute, Delhi. As panelists, I call upon Dr. Shrikant Atluri, who is a consultant uro-oncologist from Sir H.N. Reliance Foundation Hospital, Mumbai. Dr. Trinanjan Basu, who is Senior Consultant Radiation Oncologist from HCG Cancer Center, Mumbai. Dr. Abhilash Gavaraju, who is Consultant Radiation Oncologist from Apollo Cancer Center, Visakhapatnam. Dr. Amit Joshi, Professor Medical Oncology from Tata Memorial Hospital, Mumbai. Dr. Ashish Joshi, Founder, Director and Consultant Medical Oncologist of Mumbai Oncocare Center. Dr. Aparna Kardare, who is an Associate Professor, Department of Radio Diagnosis, Tata Memorial Hospital, Mumbai. I hand over the podium to Dr. Gagan, please.
Thank you so much, ma'am. And thank you for the honor and pleasure to be here for this, moderating this panel discussion, and a very warm welcome to the esteemed panelists. We have been in touch over the last few days, and it's good to see all of you in person. We will be very good boys and girls and stop exactly at the time when you ask me to. So I think the time is now only half an hour. Right, so now we have a couple of cases to discuss and a mini case, and the last case that we discuss is about metastatic castrate-sensitive prostate cancer, which my colleague and partner Dr. Puneet Aluwalia will also be discussing in the evening just before the dinner. So if we get to that, great, otherwise in the evening. So let's start off. Here is these are the esteemed panelists that we have today. Dr. Aparna, apart from being obviously excellent at her work, is also an excellent sports person. She's working in Tata Memorial Hospital. Dr. Trinanjan loves to trek, I believe. He also happens to be a radiation oncologist. Similarly, Dr. Abhilash is also a trekker and an adventurer, and he's been doing radiation oncology after graduating from Tata Memorial Hospital. He's working in Apollo Cancer Center in Visakhapatnam. And we have Sachin Tendulkar here in our midst, Dr. Shrikant. He was a uro-oncologist, consultant, robotic surgeon at HN Reliance Foundation Hospital in Mumbai. And of course, everybody here knows Dr. Amit Joshi, who loves to travel and occasionally is also found having coffee in Costa Coffee, though of course he does some work as well. Dr. Ashish couldn't join us today. We'll miss him, but that would just put additional burden on Dr. Amit. So let's look at the trends. We know that prostate cancer is one of the leading causes of death and is the second most common cancer worldwide. In India, the incidence is not as much as the Western countries, but it's increasing. It's now probably the third most common cancer here in males with a cumulative risk of 1 in 125. This trend has followed the worldwide trend where the number of prostate cancers are being diagnosed more often and with greater incidence. In fact, even in India, in a lot of cancer registries, it seems to have advanced up the ranking and is now amongst the top 3 or the top 5 cancers in most of the cancer registries in India now. And unfortunately, still in India, we get patients who are mostly diagnosed at a locally advanced or metastatic stage. This number was about 70%. Metastatic